All right. All right. So what I want to do in this first part of the lecture is talk about different types of treatments. And then we're going to specifically focus on relapse prevention. Now, when we look at treatment, we usually have some type of mechanism for a person to start taking control over their drinking life, to understand why they rely on drinking or whatever drug it may be that they're using. And so the beginning parts of treatment aren't necessarily relapse prevention. And I just kind of want to make this clear, is that the first parts of treatment is just coming to an understanding of why a person engages in addictive behavior. And also we can even kind of go even before that point and talk about detox. As you probably, for those who have taken the treatment class, probably know, it's detox treatment. And then somewhere along the way with that treatment, then you start doing the pre-relapse prevention type of group. So what I just want to do in this first part is just introduce the different types of treatment modalities that then lead to the relapse prevention component. So we'll start with probably the most well-known kind of treatment is the 12-step program. So we have AA, Al-Anon, ACOA, NA, CODA, and SLAA, and all of these deal with a different type of substance. The one that is most known is, of course, Alcoholics Anonymous, which was developed in the early 20th century as a response to the increase of addiction that we saw, especially kind of mid-century. Now, as you know, the 12-step program it began. A lot have it kind of tried to adjust itself to be culturally responsive. So a few of them talk about spirituality, but it is originally based on a Christian faith belief that you're giving yourself to God and instead of your addiction. Okay. And I should just note, and I think this is important, and then we'll get off this one and go on to the other ones, is that when you're thinking about your clients and the 12-step program, make sure you're doing it in a culturally responsible way. Now, I know a lot of Native American communities have adapted the 12-step program and made it more culturally appropriate for those communities. But it's important to state this, that the pure 12-step program, as it was originally written, was normed on middle-class white males. And we find that when a person uses the traditional 12-step program, if they're either female or in a minority group or a fringe group, it tends to be less and less successful because it was normed and based on a middle-class white man. And so when you're looking at the 12-step program, just from the get-go, that's something to keep in mind. And when you're making those referrals, make sure that the 12-step program has been adjusted for female populations if you're working with a female, and if you're working with a minority group or a fringe group, make sure that AA program you're sending them to has been normed again based on that population. So just something to kind of keep in mind when you're looking at the 12-step program. So we do have some other types of traditional models. Probably the most, and when it comes to inpatient treatment, is the one that is based on the traditional Minnesota model. And it kind of goes through kind of what we began the course with. And the Minnesota model treats addiction as a disease, that it's something that needs to be treated in some medical fashion. And so if you want to think about it, I also liken this to kind of what we do with mental illnesses in a lot of ways. So we have a detox phase where we're trying to get the substance out of the individual's body. And most commonly, especially in the inpatient, it's medically supervised during this period, especially when you're dealing with alcoholism. It's not uncommon for a alcoholic who has really it has become that 24/7 drinker, that when they start to detox, they can go into seizures, they can have brain aneurysms and all of those things. So when you're dealing with a heavy drinker, when doing detox, it's important for that to be medically supervised, so that the seizures and all those things can be addressed as the person is detoxing, okay? And then in addition to this, so you have the medical component with the Minnesota model, and then you have, the AA, the groups, drug education. So it's kind of like what we encourage with mental illness. You have the medical part dealing with the medications and all of that. And then you have the treatment part that is dealing with the psychological components of the process. The third type of substance abuse treatment, this is one I'm actually very well aware of. I helped establish one in a women's prison in Idaho, and that's what's called a therapeutic community for substance abuse. Okay, obviously in the prison setting, it's 24-hour supervision, but in even a non-correction setting, it's a 24-hour residential settings where and the best ones are communal living, meaning that individuals don't have their own separate bedrooms or own separate spaces. They all are living in a communal area. And you establish norms and responsibilities, and you have these things called encounter groups, where what you want to do is have the patients start holding each other responsible for their addictive behaviors. So, in a common an example of this is, for example, in the encounter groups, the one thing we did is, if a person saw somebody doing something that was an addictive behavior, they'd write that person's name on it and say what they were doing, and they put it in a little box. And then once or twice a day, one of the therapists would come in and say, okay, we're having an encounter group. And they would pull that ticket out, and they said, Joe observed Tom doing XYZ behaviors. And then they would have the two encounter each other and say, this is, your behavior triggered me in this way, so that the addict understands that their addictive behaviors can also trigger other individuals to behave in a certain way or go through an addictive process. And they'll talk about it, and they'll bring up the norms and rules of why they're there and how they can then work on that further. Okay. Pharmacological therapy, as you probably have heard a lot about these, methadone, naltrexone, and whatnot. These kind of have, a couple reasons. For example, methadone is meant to help with the cravings that an individual has. Some of them are meant to make the person nauseous when they try to ingest a drug or ingest a substance of their addiction. So it creates a nausea. A lot of the ones that work well are the ones that just the smell of the drug makes them nauseous. The other class of pharmacological therapy is ones, for example, dealing with alcohol. There's a medication, I apologize, I can't remember, I think it's actually the naltrexone, is that it blocks the opioid receptors. So if there's a foreign chemical going into the body, the the medication makes it so that the alcohol that then interacts with the opioid receptors, which gives you the kind of euphoric feeling, the relaxed feeling, the drunken feeling that a lot of alcoholics look for, it prevents that from happening. So basically, it takes away the whole reason for taking that alcoholic on a pharmacological level. Okay. Now, that doesn't mean, though, that the person doesn't get intoxicated. So, and I want to make this clear, it just takes away the psychological experience of being intoxicated, but there's still the coordination issues, the stumbling issues, the motor reaction to alcohol, all that still is there. It's just you don't get the quote unquote euphoric or calming feeling from the alcohol. So those tend to be the pharmacological therapies, and it's always recommended that this also be supplemented with some type of group or relapse prevention, as we'll get into. And then, of course, we have psychological therapies, and we've been talking about these all along. There's group treatment, which is probably one of the most common types of treatment for addiction. And then we do have individual therapy. And then there is couples therapy for addiction, because what we find is especially for individuals who are in an intimate relationship, they can become enablers for each other's addiction. And so there is a couples therapy that then looks at how each person in the relationship enables the other. Anyways, and then there's behavioral therapy. So we have things like aversion therapy. This is, again, where we combined something that makes a person nauseous with the addictive substance. So maybe we put something in the alcoholic drink that makes a person nauseous when they ingest it. There's cue exposures, skills training, and again, contingency matters. And we'll really get more into these behavioral ones and the cognitive behavioral therapies as we get specifically into these relapse prevention components, because this is where they're mostly used. So I just wanted to go over these to just see the wide range of initial treatment for addiction. Then as we move along, we then get into the relapse prevention aspect. Okay. So I want to just kind of mention a model of addiction to kind of understand the different models of helping. And this comes from Brinkman's. So what we have is we have two scales. We have, is the person responsible for the development of their addictive behavior? So if whatever theory you're using and is yes, they are responsible, and then there's no, it's due to some other reason. And then is the person responsible for changing their addictive behavior? So on one side of the scale, it's that the person, the development of the addictive behavior, is the person responsible or not. On this, on the other axis, we have, is a person therefore responsible for changing their addictive behavior? So let's look at the first quadrant. Excuse me. If a person we feel is responsible for their addictive behavior and they're responsible for changing their behavior, this is what we call a moral model. And probably the most famous moral model is the one that started in the Reagan era with the war on drugs. And the belief becomes that relapse, going back into the addictive behavior, is due to a crime, and so it's a criminal behavior, or it's a lack of willpower. So not only is the individual responsible for not getting addicted in the first place, and they're responsible for changing it. And so when they have a relapse, it's either because they're criminally minded, or they have a lack of willpower in some way. The second model, so let's say, so they're not responsible for their addictive behavior, and they're not responsible for changing that addictive behavior, okay? This is where we get the disease model, that addiction is something that's hereditary and is a physiological reaction, okay? And so this is a pure medical disease model, just like you would see with things like cancer or diabetes or something like that. And relapse in this case is either a reactivation of a progressive disease. So in the disease model, it is seen that a person relapse because if you think about it in the term of cancer, the cancer has come out of remission. All right. So a healthy person as a disease model is that their addiction has went into remission. And then when it gets reactivated due to a hereditary or a physiological response, that's when the disease starts to progress again. So that's the disease model of addiction. What about when a person is responsible for addictive behavior, but they're not necessarily responsible for changing that addictive behavior, that it's something that a person needs to regain in themselves, that they need. This is what we call the spiritual model of addiction. And of course, the stereotype or the represent is things like AA and 12 steps. Okay. In this model, relapse is due to a sin or a loss of contact with a higher power or a higher purpose. And that when you take away from the situation, that's when you're most likely to get into a relapse situation, is when you're entering some sinful behavior or you're losing contact with your higher power, okay? What about when a person's not responsible for the development of the addictive behavior, but they are responsible for changing that behavior? This is what we call a compensatory model, okay? And this is really what a lot of the relapse prevention programs are really based on, is this cognitive behavioral model that says relapse is a mistake, an error, or a temporary setback, okay? It's not that there's something morally wrong with the person, or they lack willpower, or that it's a progressive of some type of disease. It's humans are fallible. We make mistakes. And just to say, I'm not going to enter into that anymore, and I'm just going to resist that drug or that alcohol, is a mistake. It's an error in thinking. I kind of liken this to diabetes, if you want to, or type 2, well, specifically type 2 diabetes, which is one that is activated due to lifestyle and whatnot. Is in that, if we think about it, a person with type 2 diabetes will once in a while go have that sugary item, or that indulge themselves in a good cake or a good pie, and then they have that setback in their disease state because it makes them sick again, okay? This is kind of this compensatory model, is that relapse is not seen as some moral setback. It's not seen as lost from a higher power or anything like that. It is that we're humans and we make mistakes. But the idea is that you are responsible for then coming back and saying, okay, I did that. How do I work on trying to make that not happen again in the future? Okay, so we have these 4 type of models. And as I mentioned, these models can work together. Okay, we can start with a disease model through detox. We can try some different medications that help relieve the cravings and those kinds of things. We can use in the initial start an AA or a 12-step program for a person to understand what they're losing because of their addictive behaviors and how that has impacted their life. But then when we get to the relapse prevention is when we want to develop these skills at when I'm having a craving, how do I then prevent myself from making that mistake or having that setback? Okay, and that's kind of where we're going with this idea of relapse prevention. I already kind of talked about some of the 12 step spiritual growth. Again, it started, I think, in the 1940s, 50s, if I correct myself wrong. And there has been a lot of criticisms of it. You know, a lot of individuals have said, well, you're just exchanging one addiction for another addiction. And that has been of large debate. But again, in what we can see in the literature is as long as that AA program has been adjusted to the given population it serves, it can be very, very helpful. So again, I just want to kind of go over some of the psychosocial factors in developing and maintaining addictive behaviors. So when we talk about biological factors, we need to look at biological vulnerabilities, things like genetic predispositions. We do know that alcoholism and drug use runs in families, and it can go a lot of generations back. And so we know that there's some genetic predisposition that even if a person who knew that they had a family history of addiction, and so they resisted getting into that addictive behavior, but then they just decided to have a drink one night or whatnot, that can then turn on those genetic predispositions and start the addictive process to develop in the individual. So we got to keep those things in mind. But not all addiction is due to genetic predispositions. So, for example, when we look at cocaine and methamphetamines, the reason why they become so addictive is because they make it so dopamine sprays throughout the entire brain. And dopamine is that kind of that pleasure, that reinforcement, that motivation neurochemical that really gets the brain to want to crave that experience again. And again, when we look at this, people say, well, how can they get so addicted to that? And I just want to just kind of drive this home from the biological end. When we take methamphetamine, the most dopamine a person can produce naturally, without any external influences, such as a drug or a food or something like that, is when an individual is having a sexual orgasm. That's when we produce the most dopamine naturally. When someone has a hit of methamphetamine, take that number and multiply it by 5, because methamphetamine produces 5 times the amount of dopamine in the brain than the act that we can most naturally produce it does. So when we look at this from a biological perspective, we got to look at the brain mechanisms that are at play as well. And we got to also, as I mentioned, we have to look at the physiological response to different types of substance use. Like I said, alcohol, one being detoxed, especially with heavy drinkers. It really should be done in a medical setting. It's really unsafe for a heavy drinker to, especially cold turkey on their own without that medical supervision. Okay. And then we also have to look at the biology of tolerance, the increased frequency, and we have to constantly getting higher and higher doses. And the physiological of withdrawals, that negative effect of of quitting or of quitting that addictive behavior in the first place. And those withdrawals are both physiological and, as we'll see here in a few minutes, also psychological and socially. And so withdrawals, I want to make this point really quick. Withdrawals are just not biological. For example, with alcoholics, they shake really hard. They tend to have things like hallucinations and those types of things, especially auditory ones. So there's those physiological causes, but then with withdrawal, there's also some social and psychological ones that we need to get into. And we also have to know from a biological end that people who especially use alcohol and those are higher susceptible to different types of physical disorders. For example, one of the number one causes of congestive heart failure is addiction to alcohol. And you get what's called alcohol-induced cardiomyopathy, where the alcohol actually enlarges the heart and stops pumping the blood as much as it should, which creates a whole different realm of problems for the individuals. And then in these situations, I do have to say, is once you do have congestive heart disease, it's a lifelong thing, and the person will probably be on medications for the rest of their life. Okay. So let's talk about the psychological mechanisms that we need to take into account. And the first one, of course, is motivation. This is stages of habit initiation and stages of habit change. Often what we see is many addicts get into a routine that make it almost impossible for them not to do that substance in some way. So, for example, a lot of addicts tend to buy their addictive substance at certain times of the day. They start drinking at certain times of the day. And then the next day, they might even start earlier because of the withdrawal symptoms. And they get into this habit of doing this. And again, I'll go back to the couple example where the couples start to enable each other. Is one of them says, you know what, I'm not going to drink today. Today's the day I'm going to stop. And then, at around 2 or 3 in the afternoon, you start getting text messages from your partner saying, hey, what are we going to do tonight? What's our plans? What are we, and it comes, I have no idea. We just got to fight through this with no plan in place. And then one of the partners says, well, why don't we just make it one night more? Let's just drink tonight, and then we'll try again tomorrow, as an example. And they'll play this off of each other in order to get each other to then initiate that habit of time. And then we have expectancies, is that with a positive outcome of drug use and self-efficacy, that one can control it, and I won't lose control. When we have a different situation where a person gets violent when they drink or something, before they start to drink, they'll say, no, I'm just going to party tonight. I'm going to be in control. I'm going to make sure nothing happens. And again, once the addiction gets into its addictive process, that expectancy is lost, and the person tends to act the way that they do when on that substance. Attributions is the effect of substance use and the reason for relapse. And so, when we look at attributions, this is the kind of the triggers that we see. We know that individuals who tend to be what's called sensation seekers tend to need an excessive need for stimulation. So this is a person who is commonly commonly will seek out stimulant types of drugs, such again as cocaine, methamphetamine, Ritalin, those types of drugs. Probably one of the, and I don't mean to say this in this negative tone, kind of one of the stranger addicts that I ever worked with was a young lady who basically exercised. I think one time we measured it as she was in the dorm, so it was a controlled setting, and we could have the TAs, the dorm people, kind of measure it. And she literally, in a 1 week period, would go and exercise, running and in the gym and all that kind of stuff for up to 16 hours of the complete day. And when we started working with her, it was just because of that sensation she got from working out, that some people call it the runner's high. And that was one of the reasons why she was addicted, and I'll use this term, addicted to exercise. But it was becoming very, very unhealthy because she was losing nutrition, she was losing muscle mass, all of those things. Because, you know, as we all know, too much of a good thing is a bad thing, as you would say. We know impulsivity tends to play a role, the inability to effectively control and restrain one's behavior. We know things like negative affect. So one of the classes that we'll be adding in the next year or so to our addiction classes is something called co-occurring disorders. This is where two disorders, one being addiction and the other being a psychological illness, play off of each other. When the illness starts getting to its deepest roots, it'll use that alcohol or that drug to bring them to help control those symptoms of the disorder. And then the addiction part of it is, well, if I don't drink, for example, I'm going to be depressed, or I'm going to be manic, or I'm going to be anxious, if that's one of the disorders or one of the symptoms of that mental illness. So negative affect plays a role in that. Poor coping, this is a deficit in cognitive and behavioral skills. So this is basically, as I go back to the example of the couple, when we talked about expectancy and attributions, is that this is where a person doesn't know what to do if they're not indulging in their addictive behavior. And this is probably one of the more difficult parts of doing things like outpatient treatment, because you can provide the individuals with the skills on the outpatient level, but if taking that back to their home and implementing that, it becomes very difficult. Okay. And so those are some things that we have to consider when we're looking at the treatment of addiction as well. And then we need to look at the socio-cultural factors, such as family history. Again, if it's in the family lines, it's a very common social thing. And there's substance abuse with and neglect with children that tends to lead to addictive behaviors. Peer influence, again, is the social pressures to engage in substance use. And, you know, if we want to kind of pause here and look at peer influence, you probably have heard of the addiction culture. So that the individuals that are going through addictive processes often commonly run with individuals who also have that addiction. And they kind of think that those individuals are their only source of support, their only friends. They're the ones that understand me. And so then there's that continued peer pressure, peer influence for the individual to continue their use. Okay. And then we need to look at cultural and ethnic background. And this is the norms and religions and religious beliefs that govern the use of alcohol and drugs. And in some ways, a variation of body rates and efficiency for metabolizing drugs and alcohol. I do want to pause here for just a minute, because it's, you know, working with Native American communities, there's this myth of the drunken Indian, that all Native Americans get drunk and they get belligerent and they get mean and all of these kinds of things. And there needs to be some qualifications on that. And this is why it's important to look at your specific culture and your specific background and your people's history with drug and alcohol use. Okay, is that one, is there an idea that Native Americans are more alcoholic than any other population in the world, as we would say? And the answer is no. When we look at the European countries, especially the northern European countries, they kind of hold the record for example, alcohol consumption. They consume a lot more than what our Native American communities do. But also, when we look at Native communities, each community will respond to a drug or alcohol different based on their cultural norms and their cultural beliefs. So, for example, yes, it is true that if the tribe comes from a warring background, when they drink, do they get more aggressive? In some cases, yes. In others, no. In others, it kind of calms their aggressive tendencies down. In tribes that were more communal, we find that the whole inhibition response to alcohol really doesn't happen. And so, my point being is, when you're working on the cultural and ethnic level, do not use the social stereotypes that are given to groups for their substance use. And that's important to say. And then, of course, media and advertising. And this, again, we live, especially here in the United States, we emphasize immediate gratification. Drugs and alcohol are glorified in a lot of our movies and a lot of our media. It's always the drunken cop that becomes the hero at the end of a cop show, and all of those types of things. So we also need to look at how media and advertising is influencing the addictive process. In fact, indeed, when you're really working in relapse prevention, that tends to be a trigger for a lot of individuals that have addiction, is watching shows where alcohol is a normal thing to consume, drugs are a normal things to consume, and here it is, the drug or alcoholic who becomes the hero. And so if the superheroes and the heroes of the world can handle addiction, so can I, so I have nothing to worry about. And that tends to be one trigger that you'll run into if you do this type of work. All right, I think we need to go through that. And we have to also look at the success of things like relapse prevention and whatnot, as we look at relapse without treatment. So this is when an individual gets into decides, I'm going to abstain. Okay. And maybe they go through that initial treatment part. Maybe they start in a 12-step program. Maybe they do the medical detox. What is the basically relapse rate? So here we have the percent that abstained. So we have 100% abstainers down to 0%. And then on this axis here, we have the months, so 1 month, 2 months, 3 months, and so on. So initially a person get detox, maybe they get a medication. We find that alcohol is the quickest to relapse. Within 2 weeks, we go from 100% to 65%. But then you can see by about the 3rd or 4th month, we're almost at an equal rate, around the 40% mark. And then smoking and heroin tend to be the furthest down, that by 12 months, only 20% still abstain, whereas in the alcohol group, we're doing a little bit better. We're right around 30%. So again, this graph represents when a person initially goes into abstention, they detox, they may have some medical intervention or some psychosocial intervention in the beginning, but then there's nothing after this. And this is kind of the evidence of why it's important to then add that relapse prevention aspect later on as the treatment continues. So I want to begin our conversation about relapse prevention by looking at the cognitive behavioral model of relapse process, because this is one of the kind of top shelf relapse prevention programs, and has at least from empirical research shown to have the best outcomes when it comes to relapse. Okay. And basically in the cognitive behavioral model, what we look for is high risk situations. So this is where something in the environment, this is the behavioral part, something in the environment starts to trigger things like cravings and the need to use substance. And what we usually do is we have individuals identify all their high risk situations. Again, when I go back to the prison setting, we have them walk around and they all have notebooks. And the moment they start craving, they have to take out their notebook and write the time, the day, and then what they were doing, and then what was in their environment, what was going on in their environment, who was there other people there? Were they getting in an argument? Were they, and then we have them write down their initial thought processes. So what was happening? And we try to get them to give their honest thoughts. And so we usually tend to do this for a week or two, and then we kind of throw those out. And then we know that from there on out, we'll actually get their correct thoughts after they've kind of went through that process of wanting to really give themselves a more light than what was going on. So we have them identify these situations, okay? And then we start to put in interventions. So effective coping response, ineffective coping response. So what we want to do is put a cognitive skill in place. So one of the common relapse prevention cognitive skills is what's called a thought stopper. This is when the person starts talking about their addictive behavior, and we have them stop that thought somehow and immediately start thinking of something else. And we kind of, and in the beginning, we may see that with a lot of adolescents. We might have them put a rubber band around their wrist, and once they start having those thoughts, in order to stop those thoughts, they start flicking the rubber band, okay, to try and get their mind off of that thought, okay. Behaviorally, we start to put in coping skills that then don't lead to the behavioral aspects of driving their addictive behavior. So for example, kind of a common one is the person who drives home the same way every day, and they always drive by the same bar or the same liquor store. And they always constantly notice that they always trigger once they get to a certain point close to that liquor store or to that bar, they start to trigger. And so what do we do? Well, initial relapses is that you tell them, well, take a different way home, avoid that area, and those types of more behavioral approaches in order to keep them out of that high risk situation initially. And the idea is, and I know these sound really simple, kind of ideas, and one might argue, well, that behavior is avoidance behavior, and yes, it is. Initially, we want them to avoid that place, but the goal is to increase their self-efficacy, meaning that what we want to do is increase their belief that they can control their situation. Okay, so yeah, some of these seem kind of like manipulative behaviors or manipulative coping skills, but the goal is to get them to increase their feeling that they can control their addictive behaviors, and that then increases their self-efficacy. And then as the relapse prevention process goes on, they start to come up with their own behavioral responses and their own cognitive stoppers, as you would say, or stop their cognitive thinking. And then as the model suggests, this decreases the probability of relapse. Okay. And then when we look at the high risk situation, this is when we have those ineffective coping responses. So maybe we do once in a while try to avoid driving by the liquor store, but we don't have a plan to, right? We just kind of do it. So what's going to happen when we've had a really bad day, things have gone wrong? Well, we're going to drive by that liquor store. Okay. And this again decreases the self-efficacy, the belief that I can control this addiction in some way. And this leads to what's called the lapse. The lapse is the initial use of a substance after a period of abstaining. Okay. And this, of course, then abstinence violation effect. This is perceived effects of the substance. And then this is going to lead to a continued what we call relapse. Okay. And again, when we look at the cognitive model, yes, this is what we're working on. But the goal of this bottom line is to have 3 areas of intervention to kind of help build the person. So if they don't have the ineffective skills, we want to build those skills. Then at this next level, when we get to the lapse stage, we can do some other behavioral and cognitive interventions to hopefully not get them into a complete relapse cycle. So that's kind of the idea of having this dual model, because then as the group facilitator or the future addiction therapist, you have more things in your toolbox, because when you're facilitating a group, you're going to have probably several times someone coming in and saying, I lapsed this week, I had a drink, or I had a hit, or I had this going on. Okay. And so in your toolbox, you will want this additional tool to help that individual kind of get back to their relapse prevention treatment. Okay. So that's the idea of the model. All right. I want to explain this in complete detail, because it kind of gives all the relapse things that we do at each different phase of the high risk, ineffective coping and whatnot. So, but I don't think we're going to have time to get through it today. So I'm actually going to stop here. Let me stop sharing and let me stop recording.